Jingle.
I'll take them off so we won't have to worry about it. How's that?
3, 2, 1.
Hello. Welcome to today's program and thank you for joining us. I'm C. Virginia Fields, former Manhattan Borough President and currently the President and CEO of the National Black Leadership Commission on AIDS, Inc. The mission of the National Black Leadership Commission on AIDS is to educate, mobilize, and empower Black leaders to meet the challenge of fighting HIV, AIDS, and other health disparities in their local communities. On today's program, we'll talk about hepatitis C, treatment, cure, and support. And here today to discuss this very important topic is Tracy Swan. Tracy Swan has been doing HIV-related work since 1990. And in 1998, she added hepatitis C. She has worked at community health centers, hospitals, syringe exchange and addiction treatment programs, correctional facilities, and homeless shelters. All of these experiences have helped to inform her work as Hepatitis HIV Project Director at Treatment Action Group, TAG, where Ms. Swan combines her passion for social justice with her interest in research and policy. Tracy, thank you for joining me today, and we're just so excited to have you, especially in light of your wealth of experience. So why don't we just begin, even though I made a few statements about your background, just tell us a little bit about you and the treatment program that you work at TAG.
Well, thank you. It's a pleasure to be here. TAG is an activist-run think tank where we try to get the research that generates evidence to support policies that improve the quality of and access to health care, particularly for people who don't have great access and particularly to address disparities. We're primarily AIDS focused, but lots and lots of people who have HIV also have hepatitis C. And there are a lot of disparities for people who have hepatitis C but do not have HIV. Mm-hmm. So my project is really focused on trying to address a lot of those things, partly by doing direct education in the community, partly by being at scientific meetings, writing policy papers. I'm sort of all over the map just trying to figure out what I can do that's not being done that might need to be done.
Well, you certainly have the background for it as we look at the work you've been doing in HIV-related fields and now in hepatitis C. And of course, I'm very pleased in terms of the work that TAG has been a part of and helping to lead to Governor Cuomo making the announcement to end the AIDS epidemic here in New York State by 2020. I know that your organization has been in the forefront of that, and we've been very pleased to work in partnership, and I think this is really exciting, and that advocacy really kicked in. So you're in the right place at the right time. So now, you know, seemingly hepatitis C seemed to have just popped up on the radar screen. When I talk on radio shows or present at public forums on hepatitis C, among baby boomers, African American populations, people are amazed at the impact of hepatitis C in terms of the seriousness of the disease, the fact that many of them admittedly might have been involved with use of drugs back in the 80s or the 70s. And now to hear about this thing, hepatitis C, just seemingly popping up. We know it didn't just pop up. But could you talk just a little bit about how or when did this become so much a permanent part of our discussion, and why now?
Well, it's always been in the background, but a couple of things have really put it to the foreground. The first is that there's been a huge investment in drug development using some of the same technology that worked for HIV, and it's really borne fruit. So the standard of care up till now is really pretty primitive. It had lots of horrible side effects. It wasn't effective for everyone. It took a year and then another 6 months to even know whether people were cured or not. And I think a lot of doctors just didn't learn so much about hepatitis C, and the ones that were doing something sort of felt like in a way they were opening Pandora's box. telling someone they had a chronic illness that could become very serious, that the tools to treat it were not so great, but of course they were willing to try. So now we have great drugs, but the other thing is hepatitis C usually takes years to progress. So we had people that were getting infected decades ago, now they're getting sick. And because of the cultural things that were going on in the 70s with a lot of drug use, a lot of baby boomers got infected that way. But the other thing that people don't really talk about so much is HIV really brought infection control into hospitals and clinics. Before that, it's not that people were careless. It's just no one had really said you have to wear gloves, you have to do this, you have to do that, not just to protect yourself, but to protect the patients you're working with. So I think transmission went on in healthcare settings through blood transfusions. There wasn't even a test to find the virus.
So that leads to the other question that I think I know many people ask. What is hepatitis C and how is it transmitted?
Hepatitis C is a tiny, tough little bloodborne virus. It's pretty hard to kill. It can live on surfaces for weeks. And it's really concentrated in a drop of blood. So one drop of blood could actually be really infectious. So you think about it from injection drug use, since we didn't have and still don't really have adequate access to sterile injection equipment for people who are injecting drugs, blood transfusions, even from people getting in fist fights. And there is some sexual transmission too, but it's pretty much among HIV positive men who are having sex with other men. Heterosexual transmission is rare. It does happen, it's just not that common. But it is a blood-borne, so it's blood-to-blood transmission, unlike HIV.
And one of the things that one of our presenters often talk about when she's presenting on webinars or in public session, and it grabs people's attention, and apparently it's more of a common use among some people, I don't know them, where people use the same toothbrush. And if there is bleeding of the gum, means of transmission of blood, that too is a factor that has to be taken into consideration. You know, I suppose there are people in situations because of social and economic factors, this might happen on a far more regular basis than we think. And as well as tattoos, the tattooing, how prevalent is the transmission in your experience, especially with the tattoos?
Well, full disclosure here, I have tattoos. They're just not where you can see them. But if you're getting a tattoo in a legal licensed tattoo parlor, the people who work there don't want to get or transmit hepatitis C any more than someone getting a tattoo. So it's when people share, say, the ink wells and the ink, the needles, things like that. And with toothbrushes, tattooing, razors, a lot of this happens really commonly in correctional facilities since prisoners aren't adequately outfitted with what they need for personal hygiene. And while it's possible to get it from a toothbrush, it's probably not the most common mode of transmission.
Thank you so much for clearing that up, because that question continued to come back, and so I always have to ask it and get clear information and clarifying information, I should say. According to the data, again, African Americans appears to be disproportionately impacted by hepatitis C. Can you speak to that?
Absolutely. There's a bunch of different reasons that have to do with greater society, inequality, et cetera, that I think are relevant to almost every medical condition. But researchers discovered a genetic component also. It's called the IL-28B genotype. And people can either have a CC, a CT, or a TT genotype. And people with African ancestry are most likely to have the TT genotype.
Which most do not know their genotype.
Nobody really does unless they have a blood test. And it's not clear how important it is now in the post-interferon treatment era that we're heading into. But what that gene really had to do with is a person's response to the hepatitis C virus. So people with the TT genotype were much less likely to clear hepatitis C when they first become infected, which some people do, and less likely to be cured by interferon. It's less important now with new treatments. But this was only discovered in 2009. And for a long time, people wondered why hepatitis C was so much harder to cure in African Americans. And I think there was a bunch of squeamishness, too, about really being direct and mentioning that. But it was absolutely true that cure rates were a lot lower and that people were much more likely to become chronically infected.
And quite often the questions are asked, what are the symptoms? How does one know that they have hepatitis C?
Well, only about 20% of people have symptoms when they first get infected. Fatigue, abdominal pain, nausea, jaundice, yellowing of the skin or eyes, sometimes pain around the liver. But these could easily, except for the jaundice, sort of be written off to a bug or a virus. So most
host
people,
of other health abnormalities or issues that one might experience.
absolutely. So most people go undiagnosed, and as they live with hepatitis C, people say, they call it brain fog, like little confusion, difficulty with memory, depression and fatigue. And I mean, New York City is not the easiest place to live, so it's kind of hard to find someone that doesn't feel tired or depressed sometimes. These don't really jump
Especially
out.
after the last winter that we had, we probably could have gone through the streets. Oh my. I mean, because that was a pretty tough winter and people were really, really depressed. But I think because the symptoms are not as obvious, if you will, until the disease reaches a point almost of being chronic, in some cases cirrhosis of the liver or a person requiring to have a liver transplant. Are there other things that we could be paying attention to that might help to identify the disease or make people aware sooner?
Well, first, the law that got passed in New York to require testing of baby boomers, just if that becomes routine in your doctor's office, people talk like, my doctor asked me to have this test. Why? What's going on with that? That's one way of starting the conversation. The publicity that hepatitis C is now getting for whatever reason, whether it's cost of treatment or information about the severity, I think that's helping raise the profile. And the other one is liver enzymes are a sort of normal part of healthcare, getting your blood drawn. And if people notice they're high, it does not mean they have hepatitis C, but it might. And it's a good thing to bring up with the doctor and say, hey, what's going on? Should I be tested for hepatitis C?
How prevalent is the co-infection of hepatitis C and HIV?
The figures we say about 30% of all people living with HIV in the United States also have hepatitis C.
30%?
Yep, but if people got their HIV from injection drug use, it jumps to about 90% of that group, sometimes even more.
That's a pretty high percentage in terms of the co-infections that we're seeing nationally then.
Absolutely, and it's a really dangerous co-infection for people with HIV. And it's great that it's gotten so much easier to cure because hepatitis C increases the risk of liver-related and AIDS-related illness and death among people who are co-infected.
Okay, so now we've identified the fact that people need to get tested, become aware of their status. We've identified the fact that there's a new medication, new treatment out there that actually cures hepatitis C. So now where are we in terms of persons gaining access? How easy is that? What is the cost? Are there restrictive barriers to the medication at the other end now that they've gone through this process?
There are huge barriers, unfortunately, that are related to cost. So what we have and what we're about to get are combinations of oral drugs that cure hepatitis C in, sometimes over 90% of people that were in the clinical trials. But they're very expensive, and a lot of state Medicaid programs are really restricting access. And this is pretty unacceptable as a taxpayer. I don't fork over part of my income to see people getting denied health care that they need. And I think there's been
Just to push a little further on that point, that states are restricting access to the medication
Yes.
because of the high cost from the pharmaceutical side?
Yes, and also because of their unwillingness to allocate adequate funds to address the epidemic. Both parties, I think, are clearly at fault here.
So even though a person might become tested, decide to become tested, and they are identified as having hepatitis C, they might be restricted from getting access to the medication because of restrictions within states.
Within states and also by private insurers as well.
What is the cost for the medications now? Do you know roughly for a person who want to take the medication?
Well, here's where the funny business comes in. Sovaldi, a drug that must be used with other drugs, costs $1,000 a day, and people need between 12 and 24 weeks of it. That doesn't cover their lab work, their doctor visits, and the other medications that they'll need. But programs like Medicaid's can negotiate discounts. So they're not paying that much, nor are the insurers. I think they may need bigger discounts than what they're getting. But this is where it gets a little complicated, and that's why I think both parties are at fault, the payers and the pharmaceutical industry.
So are we making any headway or gains in terms of breaking down, knocking down those barriers?
Oh, there are
of
many
restricted
other
access?
There are many other activists around the country that are fighting really, really hard, including NATAP, the National Viral Hepatitis Roundtable. There are a lot of stakeholders, but part of the restrictions are refusing to treat people until they've already developed very advanced liver disease. They're harder to cure when that happens, and you really hurt somebody's quality of life, and it's such bad public health policy.
As a matter of fact, I heard an official of one of the federal agencies speak to that recently, and it came as somewhat of a surprise to many of us who were sitting there that there is a plan or steps actually in place now to identify the priorities of who should be treated. Those who are most chronic or chronically infected versus those who might be early in the stage of having been diagnosed.
That's part of it. There's also hepatitis C can cause other illnesses outside the liver. So if people are having, they're called extrahepatic manifestations. People have serious extrahepatic manifestations. People who are co-infected are also prioritized because hepatitis C progresses a lot more rapidly.
So what do you think about the whole idea of prioritizing people who are treated? What's the thinking on that?
I think it's really based on an artificial idea of what the resources are and a fear of real negotiation, and that if we can go wage wars, we should certainly be able to take care of people who need health care.
Very good response, Tracy. Very good response.
You.
I know that you've been also doing, and I want to make sure we cover this in the few minutes we have left, about the clinical trials. How does it work? Who can participate? And how can a person find out? And I know that clinical trials in the African American community still continues to be a major concern coming from the Tuskegee fiasco. But it's real, and we also recognize that unless populations are engaged in clinical trials, finding the right medication or responses to that population becomes more challenging. So could you speak a bit about the clinical trials, where we are, who's participating?
Well, absolutely. I mean, you raised so many good points. There is a legacy of mistrust, and rightly so.
Absolutely.
And there are good trials and bad trials.
True.
And I think a few things happen. People enter the medical system possibly with mistrust, possibly not. You can't say everybody thinks exactly the same way, but I think doctors say, oh, wow, we have African American patients. They might not want to get a trial because of Tuskegee. We're not going to talk to them because we don't want to make waves. And so people don't get information that they could be using to make decisions on their own. On the other side of things, people do get paid to enroll people in clinical trials. And sometimes people get sort of pushed into trials because they really trust their doctors, and it might not actually be the best trial for that person. So I realized that there weren't any resources for anybody about hepatitis C specifically and clinical trials, and co-wrote a little book, which is available on TAG's website, which is treatmentactiongroup.org. And it sort of takes people through like a way to figure out what the risks and the benefits might be. Now, in particular with African Americans, some of these Medicaid programs may be saying, well, treatment isn't as effective. Why should we pay so much money to cure people when it's less likely that that would happen? That was really based on the old interferon data in African Americans. We don't have a lot of data because there's been real underrepresentation in clinical trials. And I
For
certainly...
the new medications and drugs that are coming out.
Absolutely, it's been shocking, the under-enrollment. And I really think people want to enroll as quickly as possible. They don't want to take the time to sit down and really talk to African American patients. The other thing that's happening is if access is getting so difficult, a trial is a good way for someone to get treatment. It's just an important decision to make about, someone putting their own precious body on the line. Like, is this a risk I feel like I want to take?
And also, I think, part of this debate continues to be who the doctors are, who is encouraging or attempting to encourage. That's why culturally competent people who reflect the population, the gender, and the race of those they are trying to encourage to go into clinical trials is so important. And I know that there is a real gap in that area as far as African American gastroenterologists and others who are engaged in this type of work. So part of the work that we do at the National Black Leadership Commission on AIDS, as we seek to create education and awareness, we're meeting with students in medical schools, especially where they have significant, most of them don't, populations of African Americans, Latinos, and Asians, in terms of familiarizing them about this issue of Hep C and the roles that they can begin to play now, but being sensitive to what you just said, including participation in clinical trials, is all a part of this process.
Absolutely. It's so important that you're doing that. And I also think on the navigator level, the case manager level, nurses, everybody that works in healthcare, especially because these are the people that really have time to talk to patients.
Absolutely.
Sometimes what passes as insensitivity in doctors, sometimes it is. And sometimes it is bias, but sometimes it's just that they don't have the time or the capacity to really talk to people.
And now with the pressure, getting people in, send them for X number of minutes, getting them out because of the payment structure is making everybody a little crazy. But I'm so pleased for the work that you do and others around the country with respect to the whole advocacy role. So can you just speak briefly about how people can become more involved in the advocacy and awareness in building efforts to get the word out, to encourage people to get tested, and to better understand what hepatitis C is and the impact that it's really having, especially in the African American community?
Well, there's some national groups like the National Viral Hepatitis Roundtable. They're doing access work and all sorts of levels of advocacy. New York City has a hepatitis B and C task force. And then there are a lot of community-based organizations that are starting to do work. And I think also if people are affiliated with an organization in their community or clinic, just to be their own advocate and say, hey, I'd like to find out if I have hepatitis C, and so would people in my community. How can we do that? I mean, that's really what transforms the response to an epidemic, the response within a community.
You've been a wealth of experience in terms of sharing rather your experience. Is there anything else you think you would like to add for our viewing audience that we have not covered in about a minute?
Just that I have a great role providing technical assistance. Our website has a lot of information, but communities are what really change an epidemic.
and we need to be more out there in terms of engaging the community. And that's kind of ironic because that is certainly the area where we're seeing fewer dollars or funding to support those kind of efforts. But because of the work that we do, we recognize in order to really turn the corners, we've got to be able to educate, create awareness, and engage people more. But the funding is not there, and we're just having to constantly find new ways to do the work.
It's true, it's really frustrating, but it's so fantastic that there are other people doing it, that your organization is doing it, and that we try to make the most of the limited resources that we have.
As I often tell people in government, my friends as a formerly elected official and often go into government too for public dollars, that government really has a major role in terms of supporting nonprofits to do the work, because there's no way that government can, nor should government be engaged at the community levels in this way. So I really want to thank you. I want to thank you for the work of your organization. For the advocacy, the policy lead that you take, the policy work that you take, rather, in bringing a lot of this to the attention of the public. And let's continue to work and go forward.
Fantastic, thank you so much.
So I'd like to thank Tracy Swan for joining me on today's program in leading the discussion on hepatitis C, treatment, cure, and support. For more information on this subject and issues related to HIV/AIDS and other health disparities, please visit NBLCA's website at www.nblca.org or look for us on Facebook and Twitter. The Manhattan Neighborhood Network brings these programs to you to better inform you, the viewer, about the important topics that impact your health and well-being. Please let your family, friends, and neighbors know about this programming. Once again, I'm C. Virginia Fields, and I thank you for joining us and hope you'll tune in next time for In Black's Health Action TV here on Manhattan Neighborhood Network. Okay.
Thank you very much.
Thank you, Tracy.
Thank you.